The Sepsis Six is the resource which empowers every health professional, no matter what their background or level of experience, to act decisively when faced with someone with suspected sepsis. There are of course 6 steps to the Sepsis Six. Step 1 is to inform a senior clinician. That's to ensure that care can be coordinated rapidly. It's also to ensure that people can look for alternative diagnoses. Contact the person with the most experience in looking after people with conditions like this to help to guide the very best strategy. Step 2 is to give oxygen if it's needed. Now, some people with sepsis won't need oxygen. Their oxygen saturations will be normal or good enough. But in many patients with sepsis, the oxygen saturations can start to fall, and sepsis is a critical imbalance between oxygen supply to tissues and demand of those tissues. So we can't allow oxygen saturations to fall below normal. Step 3 is to send a full set of bloods, including blood cultures. Now that will include full blood count, urea and electrolytes, clotting studies, studies to look at liver function. It will include blood cultures, lactate, which is a non-specific marker of badness, as well as more modern tests to give us rapid information about the type of pathogen that's involved and its likely sensitivity to antibiotics. Step 4 is to give intravenous antibiotics according to local protocol and think about source control. Now, local protocol means you need to think about where the infection is and give targeted antibiotics. If you really have no idea, then we're going to, in that situation, use broad spectrum antibiotics according to local protocol, but that should not be the norm. If a patient has a source of infection, an obvious example is a pelvic abscess that is amenable to drainage with interventional radiology, surgery, or removal of a device, then it's every bit as important as giving antibiotics that we control that source. If the patient has septic shock, within 6 hours at most. If they don't have shock, within 12 hours at most. Step 5 is to give intravenous fluids and consider vasopressors. Every patient should be given intravenous fluids in divided boluses of 250 millilitres. But in people who aren't responding, we need to be prepared to repeat those fluid boluses. And if we're approaching the delivery of a litre of intravenous fluid to an adult patient, then we need to think about whether they might need vasopressors. That will involve a call to critical care, of course, for their support, but we need to ensure that we don't flood patients with fluids, because too much intravenous fluid resuscitation is known to be harmful. And the final step is to monitor the patient. And this means setting a monitoring plan, setting the frequency of measurement of NEWS2 score, making sure that accurate urine output is measured, that does not always need catheterization, and ensuring, particularly if the initial lactate was abnormally high, or if the patient's clinical situation changes, that we measure repeated lactates to assess response to treatment. By doing these 6 simple things within the first hour for someone at high risk, we can greatly reduce the chance of a patient dying.